Hey guys, welcome back to second semester. I'm going to tell you about a patient we saw this week who was a new consult for us. He was a 40-year-old Caucasian male. He said his chief complaint is probably both depression and anxiety. His HPI, this patient has a waxing and waning course of depressive episodes, which may have been going on for years. The patient did not really notice until about a year ago when he started working as a custodian at one of these schools. Prior to that, he was working alone cutting lawns. So he would respond to his depressive episodes in the past by throwing himself into work. However, now as a custodian, he's having more social interactions with other people, and it's revealing the patient's depression. The patient endorses recurrent episodes lasting 2 weeks with dysphoria, insomnia, stating 3 hours of restless sleep per night, inappropriate feelings of guilt and worthlessness, decreased energy, decreased concentration, increased appetite with a 5-pound weight gain, both psychomotor slowing and psychomotor agitation, and thoughts of suicide. In 2002, when the patient was drinking, he loaded a shotgun and had thoughts about shooting himself, but he never attempted suicide. The patient's never had a manic episode. In the summer of 2021, he experienced an episode of psychosis with auditory hallucinations, and he saw a pterodactyl. He said, "I would hear things and I was hallucinating and I was at an all-time low. I was worried someone would get me." So he was having persecutory delusions. I think that he did have an episode of psychotic depression at that time. The patient has failed trials of citalopram, Buspar, desvenlafaxine, and lamotrigine. And that's why he was referred to us. We'll diagnose him with major depressive disorder, recurrent, moderate, with a history of psychotic features. We discussed the risks, benefits, and side effects of duloxetine, and the patient consented to treatment. He has failed 2 SSRIs and 1 SNRI, and after duloxetine, the next trial we would try would be bupropion. He said, "I worry about everything. I worry about my wife leaving me. I have insecurities all the time. I worry about a place to live. I worry about money." This patient endorses years of excessive and bothersome daily worries, which he says cause fatigue, restlessness, irritability, and initial insomnia. We'll diagnose him with generalized anxiety disorder. And although duloxetine is not approved for the treatment of generalized anxiety disorder, it might be beneficial, and the patient is worried about taking multiple medications. So hopefully this will prove effective for both his depression and anxiety. Before coming to the clinic, the patient weaned himself off of all the previous medications he was taking. The patient first began drinking at the age of 13. His last use was at the age of 20. At his peak, he said he consumed 30 to 50 cans of beer per day. His wife was surprised by that number. He endorses withdrawal shakes using larger amounts for longer than intended, unsuccessful efforts to cut down, increased time spent to use, obtain, or recover, decreased time in social, occupational, recreational activities, persistent craving for the substance use resulting in failure to fill role obligations, continued use despite interpersonal difficulties, and continued use despite psychological difficulties. He became quite dysphoric with his alcohol consumption. In 2002, after holding the shotgun that was loaded, and he had those thoughts about suicide, he was admitted to a psych ward. He was assessed and then transferred to another treatment facility, which I won't mention just because of HIPAA, for chemical dependency treatment. He completed the program there and remained abstinent from alcohol since then. We'll diagnose him with alcohol use disorder, history being severe, but in full sustained remission. We recommended 100% abstinence from alcohol, and he and his wife were both agreeable with that recommendation. Psychiatric review of symptoms. Patient denied symptoms of mania, panic, PTSD, OCD, somatization, eating disorder, or ADHD. Substance use history, we covered the alcohol. The patient smokes about 2 packs of cigarettes a day, and he chews he doesn't chew. He drinks coffee. He says, I love it. We strongly encouraged abstinence, but the patient disagreed with that recommendation. The patient did have an experimental use of cannabis in the past, but otherwise denies a history with illicit substances. His past psychiatric history includes the loaded shotgun in 2002 and then being hospitalized. He's never been violent towards others. He denies ever having a seizure. He was only hospitalized that once in 2002. He did have a motor vehicle accident in 2007, and he struck his head against the windshield and was knocked unconscious for a few minutes, but not hospitalized. He's not currently prescribed any psychotropic medication. In fact, he's not on any medications and hasn't been for over 4 weeks. Psychological trauma history, the patient states that he was molested as a child, but he has not talked about his therapist with this, and he said he does feel like he's going to bring it up with a therapist soon, and he didn't want to talk about it today, and he denied symptoms of PTSD. His medical and surgical history is unremarkable. Before he weaned off those meds, he did have an albuterol inhaler. He would use PRN. He has an EpiPen injector, and the only other medication he had was commit lozenges, which he was not having success with. So he is allergic to bee stings, penicillin, and pollen. Psychosocial history. The patient was born in a town in Minnesota to married parents. He's the fourth of 4 children with 1 brother and 2 sisters. He denies a history of physical abuse, but does endorse the history of being sexually molested, which he didn't want to discuss today. He did graduate from the 12th grade, and he used to mow lawns, but now he works at a school as a custodian most of the time during the night. He's been married for 10 years, and he says that he found the right one. He has 4 children by 3 different women, and he's struggling financially. He denies legal issues. His hobbies include 4-wheeling, and his strengths are he is friendly and talkative, and he's non-denominational Christian. His family psychiatric history. His sister has been diagnosed with depression, brother with depression and alcoholism, and that brother committed suicide. The review of systems, he occasionally has headaches. Otherwise, he denies difficulties with weight loss, vision, hearing, smell, taste, touch, dizziness, chest pain, shortness of breath, nausea, vomiting, diarrhea, constipation, urinary problems, bleeding, pain, weakness, incoordination, or neurological difficulty. Today, that wasn't today. At a previous office visit, his PHQ-9 score was 19. And sorry, I'm just scrolling down here. His HUDAS was 2.0. His risk of violence towards others is low. His mental status exam, he was well-groomed with good eye contact. He's pleasant and cooperative with the interviewers. He was alert and oriented ×3. His speech was of regular rhythm, rate, and tone. His motor was within normal limits, no psychomotor agitation or slowing. His gait was normal. His mood was, quote, I'm doing really good. His affect was full, appropriate, no lability. His thought process was tangential and circumstantial. Associations were goal-directed. His attention span was intact. Recent remote memory was intact. Fund of knowledge was intact. And language was intact. There was no suicidal ideation, no homicidal ideation, no delusions, no hallucinations. We consider his judgment and insight to be good. So for the diagnoses, we did major depressive disorder, recurrent and moderate, generalized anxiety disorder, and alcohol use disorder, history being severe, in full sustained remission with the last consumption being in 2002. So for our plan, we provided psychoeducation of the patient's diagnosis, prognosis, and treatment, recommended 100% abstinence from alcohol, recommended AA once or twice per month. The patient said he does get a great benefit from AA. We recommended that he return to psychotherapy with the therapist he was seeing. The patient has failed the Buspar, citalopram, desvenlafaxine, and Lamictal. So we discussed the risks, benefits, and side effects of duloxetine. He consented to treatment. We started at 20 milligrams, 20 milligram capsule in the morning, and if he tolerates that well and feels somewhat beneficial after a month, we'll go ahead and increase that dose if we need to. We will keep the bupropion as the next option in the future. And we did do GeneSight testing today. He said he feels like sometimes meds hit him really hard and other times they do nothing at all. We are going to have him return to the clinic in 4 weeks or sooner if problems arise. We'll review how he did with the new Cymbalta and his GeneSight results. Thanks for watching.